Welcome to another episode of Warrior1 Spine, and we're going to be digging deep into hyperkyphosis today. But before we get started, I just wanted to do a little mini intro and once again thank Pascal, Dr. Pascal, for allowing us to go deeper and deeper into spinal reconstruction and understanding not only the research but also the application and the corrective protocols. But we just talked with Pascal before the call started, and we're just talking. I had a moment yesterday actually in practice where the place is just lit up and we have three doctors on. So like I'm on one side, Ian's in the middle, and Yuri's on the other side, and we're all really busy and everybody's, full lit hot seats and stuff. And it's just that moment of just simplicity where people are coming in, scanning their card, x-rays are sent to, the tables, and there's, waiting, and they know the protocols, and they actually get onto the table, get adjusted and leave. And it's just that flowing moment. And I was just telling Pascal, it's just so amazing to see that simplicity, but that there's a depth of belief that allows simplicity to take place. And I just wanted to go there for a second, or maybe a little bit longer than a second. But so a few weeks ago, I actually posted on social. I posted Tony's story, or Tony's story was posted for us. And Tony's 35-year-old chronic severe neck pain, back pain, arm numbness, and it was a pre and post X-ray. And then I got some feedback. I got some replies, and the first reply was from this guy that says this clearly shows two different head positions not improving, and then it was quickly followed up by a woman that said followed by a 3-time-a-week treatment for a year or so. And it was interesting because I saw the replies, and I'm not really good at social in terms of replying to the replies and stuff, but then Holly kept on reminding me, hey, you should reply. And I just didn't feel like, I mean, I know what I could have said, on the first person's Facebook page, their byline is basically love all, serve some, and trust no one. So just with the type of personality I have and just some of my gift package, I could have went in and just say, okay, I know why you're saying this because of your motto, right? But I did it, and I just kind of like marinated on it for a while, and I was just asking God to give me a great response. And then, so if you want to watch the response, I'm not going to go how I responded, because you can watch the video on YouTube or Instagram, Warrior1 Spine. It's also up on the Tactical Training Center. You can watch it there. But I wanted to show you how I responded from the structural perspective. So advertising, BJ. Okay, now in the green books, just when I start off very quickly, I don't believe everything that's in the green books. Where we would differ greatly would be my spiritual beliefs. I don't believe in the spiritualism that he was using. I don't believe with some of the definitions he's used to define, spirit and soul and things like that. So, but there's a lot of great stuff there. Okay, so when you do read the green books or any book, eat the meat, leave the bones behind. And when I read the Bible, it's all meat to me. So if that makes sense. But I just wanted to go through a few things here. If a man is dying for the need of chiropractic adjustments, and as thousands are doing every week, and these dying and thirsting for the correction that only chiropractic can bring, they may refuse the drink because they do not recognize that to them it is the water of life. In other words, people may be dying for the need of chiropractic, and yet they still refuse, unless, get this is the important part, unless they have been educated to its character and the need for it. Advertising is simply the education of the public. Advertising chiropractic is bringing life to the dying. Chiropractors advertise because they believe that to sell chiropractic is not a privilege, but a duty. And selling chiropractic, like I believe, I've never sold chiropractic at all. I just tell stories, right? That's all I do is tell stories. In 1922, BJ was, outside the box. He was one of the first pioneers in radio. and he bought WOC, which he's, coined Wonders of Chiropractic. And one of his, in 1933, this is Ronald Reagan, believe it or not, who actually was one of the first announcers on his channel. And he actually had another radio, ended up buying another radio station, and then Ronald Reagan moved to that radio station. But just cool stuff, right? But what BJ did is he wanted to get the stories out, the story of chiropractic and the stories out. And he did that as a first pioneer in radio. And so imagine now what we have available to us, but we've just created such complexity. Must sell chiropractic. However, it is not sufficient to study chiropractic in the world's best school, to know it thoroughly, and to go back to your hometown with a diploma in your trunk. You must sell chiropractic. And how can this be done? First and foremost, you must be sold on it yourselves. So the story, you have to be sold on the story yourself. You have to remember the stories and remember all the stories. And you have to become an expert in telling that story. And this brings us to the matter of explaining chiropractic to prospective patients. By all means, explain it so people can understand what it's all about. Simplicity, right? So how do you educate about chiropractic? Education is useful if it is simple. If education is simple, it is useful. Chiropractic was born a simple principle and practice. When chiropractic was simple and chiropractors were simple, chiropractic and chiropractors were getting sick people well. Listen now, listen. Those that lived simple chiropractic succeed. Those that lived complex chiropractic fail. I want you, if there's one thing I want you to hear today, is simple makes, simple creates, complex breaks. So coming back to the story, so how am I going to respond to this? Well, the way I first responded is that he's calling me out. So I'm getting baited here. I don't know what the technical, I think it's bait, like they're trying to bait me out or whatever. I don't know if it's a real person, maybe it's a bot, who knows, but whatever, okay? But how I said is, yeah, I said to this person, yeah, there's two different head positions here. Absolutely. And you guys know it because you can see hard palate. One's flex and, anterior and flex forward, and hard, second hard palate is more level, right? But I had to go into the reason why. So initially, Tony couldn't bring his head up. MRI revealed there's a massive disc bulge at 5'6". He's in an acute episode. He can't even move and he can't bring his head up. So obviously he's in two head positions, right? But then I got to go deeper into the story. And it's a simple story. The simple story is poor posture leads to serious spinal degeneration. So if you have poor posture, you're going to have serious spinal degeneration. Or maybe it's just your serious spinal degeneration is what's causing your poor posture, because posture is the window to the spine. So you got bad posture, you got bad spine somewhere. And these are just symptoms of bad spine, right? And then you go deeper. And we know what? The loss of cervical curve. So we start off with structural damage. Green light, red light, green line to red line. Green is good, red is bad. There has to be an ideal or close to ideal. We have to be moving towards something. But what we know is that when it's not aligned and when it's out of ideal, that's what we call subluxation. Okay. The loss of cervical curve, now structural damage leads to neurologic damage. And I'm not going to go through everything. But you have to go from subluxation, then structural damage leads to neurologic damage. Neurologic damage includes the nerves, the impingement of the nerve system, but it includes neuronal loss due to chronic cord compression. Let's go deeper. What does that look like? Well, this is what it looks like in Tony. Now, obviously, this is not Tony, but he had a massive bulge at 5'6". This is what's happening. Spinal cord compression, stenosis. Brain is now getting disconnected. There's a disconnection from body. Decreased light flowing through that spinal cord. It's simple. Now, coming back to followed by a 3-time-a-week treatment for a year or so. No. Have I had people at 3 times a week? Yeah, I got Wolf. He's 3 times a week. He's gonna be 3 times a week forever if he wants to keep on walking, you know. But in Tony's case, it wasn't. In Tony's case, it was 3 times a week for 13 weeks. It was twice a week for 13 weeks. It was after 6 months, we re-x-rayed. And that's what it looked like after 6 months. And after 6 weeks of care in our clinic, we started a home cervical traction protocol with different types of, you know, units, maybe depending on what they need, or some blocking eventually. And you know what? Keep it simple. Why do we do that? Because we want to bring back the curve. Because when you bring back the curve, you take the pressure off the spinal cord, increasing power between brain and body. It's easy. They get it. That's what we're after. But then I go, oh yeah, you know what? Well, that's Tony's story. Now they understand, right? There's a deeper understanding. And I took time to reply with this video. I sent the video to them. Haven't heard back, but I sent the video to them. That video that I did took a while, but it was worth it. But it was simple. So when I talk about Tony's story and I explain it in the depths of Tony's story, now they're going to understand their story better. Then I can go like, well, look at Vincente's story. He's 32 years old, neck, low back, leg, before, after. Well, now they understand. Well, he probably did 3 times a week for about 13, twice for 13. You know, he probably started tractioning, right? And they have language. Like BJ was saying, is that you have to give them language. You have to give them the why behind what they do. Your procedures should be just about getting the story from them, hearing the story, sharing the story about what you do and what you specialize in to change other people's stories. And then it's offering them the solution of whether they want to transform their story with your story. And if they do, great. And if they don't, great. And the people that they do, it goes well beyond pre and post x-ray. This is why we do what we do. This is Vincente. That's 1,000 words. Each image is 1,000 words. This image is a transformed life, a transformed future. Look how great he looks, right? But you guys do this over and over again, year after year, decade after decade. You've had thousands and thousands of stories. Wake up to those stories. Get better at telling those stories and get those stories out. Because there's Rakayas out there, and there's the B's out there, and there's the Coach Anthony's out there, and there's the Stewarts out there, and there's the Jackies out there, and there's the Simons out there. And they will go out there to inside based on belief and storytelling. Yesterday, I took these photos. See, this is our front desk. So you can just see first poster, story, second poster, story. Behind the posters, big screen TV, testimonial, there's story, right? On the other flip side of those posters, another poster story. You know, another poster story. Everywhere you look, all you can see is story in the clinic. You know, we've got 3 big logos in different places. You can't stand in the clinic without seeing real people, real stories. Behind this, on the other wall, you can see Chiropractic with Compassion and 1,000 more stories. Right? At the T-bars, change your story, change another, share your story, you know, click here. On the walls, the stories. Everywhere you look, it's all about stories, because that's what you're supposed to be all about. You share the story, you'll hear their story, share the story, invite them into your story. And if they say yes, great. And if they don't, great. And you move on to the next person that's actually willing to transform their story. And that's all I had to say. Pascal?
Okay, so I'm assuming that a lot of you are doing these in sequence. And again, I recognize tons of faces, so I know a lot of people have been following. So if this is the first time, obviously, you always have homework to go back, watch previous webinars, because some of these concepts might be over your head, you know, 37,000 feet, that's okay. The goal is to get a little bit of understanding and continue to improve our knowledge about the mechanics of the spine, how to reconstruct the spine. And I always want to build in sequence. And the more we master this information as chiropractors, the easier it is to, tell the stories. The easier it is to get results, which help patients tell us those stories, just like Dr. Ed was talking about. So I started this here on the whole theme of the coupled motions of the spine. This is really important to understand, even just like that last pre-post x-ray you showed us, right? Head down, head up. Is that going to account for all of the curvature change? Actually not. And most of any curvature change with just head position is going to happen at C1, 2, and 3. And usually it's limited to 9 degrees. So any curve change over 9 degrees, it's impossible that it's just head positioning, because you can't get more than 9 degrees of cervical change with tilting the head. So this kind of information, you own it, and then you can respond to, we'll call them attacks, or people who are just unfortunately uneducated in this stuff, right? So we talked about coupling patterns of the cervical spine last time. Today, I want to talk about coupling patterns of the thoracic spine. What happens to the thoracic spine as someone translates forward and backwards, AKA, their torso shifts forward or their torso shifts backwards. And that's going to help us also understand the difference between structural and thoracic hyperkyphosis. The reason I'm bringing up structural and thoracic hyperkyphosis is because when the thoracic spine translates backwards, we're going to see an increase in kyphosis. And some of that might be normal. It might be postural. And so when we're looking at someone that is kyphotic, rounded in the thoracic spine, we need to know, is it structural? Is it postural? Because that's going to determine what home care are they getting. Are they getting a thoracic general? Are they getting a posture regainer? What exercises should they be doing? So it's really important to know that stuff. So if a lot of you are only doing cervical x-rays, you'll hear me repeat this over and over like a broken record. I think you should be doing lateral thoracics and or lateral full spines, because it is important to understand the whole global view of the spine from the side. If you are only doing cervical x-rays, though, these measurements are ultra important, because they should, tick off some alarms in your brain or get your spidey senses tingling. Remember last time we talked about the coupled motions of the cervical spine? I mentioned numerous times, anterior head translation up to what? Hopefully I don't even have to say it, and those who are watching are all going 50 millimeters, doc, 50 millimeters. So 50 millimeters is kind of that threshold cutoff. If you start seeing values of 50 millimeters of anterior head translation and larger, almost for a fact that is being generated by a hyperkyphotic thoracic spine. So you do not want to give that patient head weights. You do not want to give that patient a cervical general. That person needs to do some thoracic rehabilitation or reconstruction. Okay, so large measurements. And I mean, that measurement could be 47 millimeters, right? It doesn't have to be like, oh, it's 47, it means it's cervical. No, if you're getting close to that 50 range, those high values, make sure you're paying attention to what's happening in the thoracic spine. So how can we confirm that? Or what's our secondary test is to look at these values, the slope of C7 and T1 relative to vertical. So again, simply, it's just a vertical line. If I put a vertical line up from the bottom of T1, if I look at how sloped my T1 is, if that value is above 30 degrees, and if everybody understands angles to some extent, I think everybody's going to appreciate that this angle right here is 45 degrees or so. We don't even have to measure it. We can see that's well over 30 degrees. And the reason it's so tilted forward is because the person has thoracic hyperkyphosis. And so if that person has a very strong tilt angle above 30 degrees, again, your spidey senses should be tingling about looking at the thoracic spine, okay? Now, when you're going to take your thoracic x-rays, again, I'm a huge proponent of lateral full spines. Here's the reason why. Here's the exact same patient. I took his lateral thoracic x-ray, right? And then I took his lateral full spine x-ray just for a comparison difference. Good friend of mine, he let me do this as a project so we can use it for teaching purposes. So if I look at his lateral thoracic here, I'm like, oh yeah, he's got a little bit of thoracic hyperkyphosis, no big deal. If I look at his entire full spine picture here, I'm like, oh wow, he has quite a bit of thoracic kyphosis. He translates backwards a little bit. He's actually really flexed up top in the thoracic spine, driving his head forward. This tells me so much more about how to address the overall position of the person versus simply a lateral thoracic. Some people might not have the capacity or software, so at least the lateral thoracic helps us. But understand that most softwares now can stitch these films together. You can take a lateral cervical, a lateral thoracic, a lateral lumbar, and the software allows you to stitch them together to get a full spine view. That's how we do them. We don't have a lateral full spine cabinet, okay? So when you can, try to take the lateral full spine view. So what are normal measurements for the thoracic spine, and how do we measure them? All curves in the spine are measured the exact same way, the posterior tangent method, or using like what we call George's line. So in the cervical spine, we used C2 and C7, and we drew our lines down and measured the arc. Pardon me. In the thoracic spine, it's no different. If we can, we're going to use T1 and T12, if we can. And the reason you have T3, T10 here as an alternate is because sometimes this area gets quite shaded in the shoulders. You got those really thick patients, think about someone who's, as broad-chested as they are in the stomach, a football player, rugby player, someone that's really broad in the chest. Sometimes it's really hard to pierce through that collarbone area and get a good film. So then we can go down and measure it from T3 through T10, but we get different values because they are different pieces of the arc. So if we're using T1 through T12, we're approximately 44 degrees. And if we're using T3 through T10, we're going to have a smaller arc, 37 degrees, right? So let's say this was my T1 here, right? That yellow line represents the back of T1, and I just draw it down. Okay, I draw it all the way down till it intersects my line coming up. I find my T12. We'll say that's T12. I put my line up behind the body of T12. Sorry, I'm trying to draw this freehand with my mouse. I would draw that till they intersect, and I measure that angle between the two. This guy's measuring 30 degrees. So from T1 to T12, if he's 30, and I told you that 44 is normal, we know he has a slightly reduced kyphosis. Okay, so this is not someone that we're putting on a thoracic dental roll because it would flatten the thoracic spine more. Okay, but it's important to measure it because there are going to be times when you're going to see flattened thoracic spines, specifically when someone translates anterior. So we're going to touch on that here shortly. So we talked about coupling patterns. So the coupling pattern happens when the spine shifts forward or backwards. And this is the confusing part. Thoracic translation is measured on the lateral lumbar film. This confuses people a ton. Thoracic translation is measured on the lateral lumbar film, okay? Because you have to think about it. We are taking this block right here, and translation means that block has moved in an entirety forward or backwards. That's translation, okay? And that happens when we go down to the lumbar spine right here. So I'll just pretend I'm going to draw this like block here. Here's my thoracic spine, okay? It moves anterior or posterior. And if it's going to move anterior or posterior, that's going to happen in my lumbar vertebrae. So we measure T12. We find that inferior corner, right? We've done this all before. These are all measurements you've all seen before, okay? So T12 posterior, inferior corner, right? Or you could use like points, but this is the standard. So I use the inferior corner of T12. I use my inferior corner, that's my S1. So I use my inferior corner of S1, and those should line up or pretty close to it. If, I'm way out here, it's anterior translation. If I'm way back here, it's posterior translation. So I've given you an example of each to make it very clear. So here's my T12, right? I find my inferior corner. Let's pretend this is a perfectly vertical line. I draw it down. I find the inferior corner of S1. I draw it up. And I imagine everybody can appreciate that this is shifted forward. That's anterior translation of the thorax, okay? Yes, the lumbar spine is also translated forward, but it's anterior translation of the thorax. Conversely, here's posterior translation. So here's my T12. I draw my line down from the inferior corner, okay? I find my S1, I draw a line up, and everybody can appreciate that that's gone backwards. That's posterior translation of the thorax. So now let's talk about what do anterior and posterior translation do to the thoracic spine. What do we see, okay? If it's anterior translation, you're going to see a flattening of the thoracic spine. You're going to see a reduction in thoracic kyphosis. So here's an example of anterior translation. 5, 4, 3, 2, 1. Here's T12. I draw a line down. I find S1. I draw my line up. Everybody can see that, let's use a random number. Let's say it's 35 millimeters. There's 35 millimeters of anterior translation in this thorax. If I measure this kyphosis, and I don't have the measurements here, but I can appreciate, I know for a fact it's reduced. And so much so it's reduced. I mean, you have a decent kyphosis up top, but he's actually almost even lordotic here in the lower thoracic spine, which is very common with anterior translation, okay? So if I had this patient shift backwards and teach him a proper exercise, he might actually have a perfectly normal thoracic kyphosis. And here's how I know, okay? If the thoracic kyphosis is reduced only by marginal values up to about 13 degrees. Okay, I'll repeat this again many times throughout this presentation. The max value in change in kyphosis, whether forward or backwards, is approximately 13 degrees. Okay, so if this person shifted really far forward, we could reduce his kyphosis by about 13 degrees. So if I'm measuring T1 through T12, I'd be at roughly 30, we'll say, pretty close. And then T3 through T10, about 25 degrees. So if this person was shifted really far forward and I measure a 30-degree kyphosis, all you got to do is teach that person how to shift backwards and their thoracic kyphosis will look perfect. Then someone can argue that, hey, it's just changed the position. Yes, we did change the position. We changed them from their old normal to their new normal, which is healthier for their spine and nervous system. So understanding those coupling patterns are very important. Now, if the person is shifted forward like this 35 millimeters, and I measure a 15-degree thoracic kyphosis, that is well below my threshold of 30, I know there are ligamentous problems. So owning these values and understanding this is so important to help guide what you're going to do with a patient. Am I going to lay this person prone on a roll to try and increase kyphosis, or am I going to focus on exercises to drive them backwards? These are your measurements to help you understand. So large anterior translations can reduce the thoracic kyphosis by approximately 13 degrees. Okay, and you're thinking about 30 from T1 to T12 and about 25 T3 through T10. So if your values are significantly less than that, there is ligamentous damage to the thoracic spine. All right, let's talk about the one we're going to see more common and we're probably more interested in. Posterior translation. Same principle, okay, same values, same concept. This time we go backwards. So if we go backwards, we increase the thoracic kyphosis up to approximately guys, again, there's human error of measurement, right? So again, if someone's going exact values, because the research tells us 13 degrees. So if I say 44 plus 13, someone's gonna be like, doc, that's exactly 57. Sure, but if I'm measuring an x-ray versus Dr. Ed versus Dr. Yuri, it's possible that we have 2 or 3 degrees of variation, okay? So your values down here, someone has a large shift backwards, I put roughly 60 degrees, give or take a couple degrees, right? And here's a perfect example. Someone might say, and they might ask this question, which I normally get is, well, what's a large translation? I'll tell you that a max translation is about 75 millimeters or 3 inches. Any more than that, you're going to start to see significant compensation with bending the knees and like true collapsing of the spine. So if someone's standing with their knees straight, about the max they can shift forward or backwards is 3 inches or 75 mils. Okay, so I put up this x-ray because this is one of those, like the classic teaching example. If I look here, she is shifted backwards by 74.5 mils. Let's call it 75 millimeters. Textbook, perfect example, okay? Her thoracic kyphosis measures 59.5 degrees. So I know beyond a shadow of a doubt that if I just have her straighten up and I really work that posture and get her to stand up into a neutral position and I retake that x-ray, that thoracic kyphosis will be 44 degrees, okay? There is no structural deformity in this spine. This is 100% postural retraining, 100%. Okay, this concept is important, and if we didn't understand it, we can ask questions about it after. So I made a graph to try and help people also understand this concept. So here's the same lady, okay? I'm just showing this as posterior translation. So from no translation all the way up to 75 millimeters. 0 increase in kyphosis all the way up to adding 13 degrees, right? So 0 kyphosis, so normal, this would be like 44 at my 0 line, and let's call this, the 57 or roughly 60. As I shift further and further backwards, we're seeing an increase. As they go further and further, we're getting a larger and larger increase in kyphosis. And the same principle happens as they shift forward. Now, is this published data? No, I just created a linear regression analysis to help, elucidate the concept, but I think you get it. If someone only shifts back 15 or 20 mils, they're not going to have necessarily a 13-degree increase in kyphosis. And so you can use something like this to try and extrapolate your values. So if someone's got 35 millimeters of translation, I might expect approximately a 5-degree increase in thoracic kyphosis. Or if it was forward, a 5-degree reduction. So you can help hopefully understand that the larger the translation, the more increase in kyphosis and vice versa. So again, why is this important? Because it helps us dictate when it's a structural issue versus postural issue, and it tells us what we need to do for home care. So This is, again, that same case I've been showing you over and over. She's right here, okay, the perfect postural case. She has no structural deformity. I'm going to send her home with the posture regainer, aptly named to regain your posture. And I'm going to have this person do tons of Titanic exercise. If you don't know what the Titanic is, you can go to my YouTube channel after. We've talked about it. It's my favorite postural exercise for this posture. On the other hand, here's a true structural deformity. Okay, and here's how we know the difference. I'm going to come to his curve at first. Right here, he has 66 degrees of kyphosis, and he has virtually no translation whatsoever. So if I take his inferior T12 and I draw it down, it's almost perfectly lined up over his inferior S1. So if he has no translation forward or backwards, there is no increase that is due to a coupled motion. So he truly has a structural deformity where his bones are being held in that position. This patient needs a thoracic dental roll. We need a sharp peak. We need a more specific bending moment. We need that to fit between the shoulder blades because we also want the weight of the thorax to sort of push back, or so I guess the weight of the shoulders to help as like a counterfulcrum to really stretch the thoracic spine. This is way harder to change than this. Structural is way harder to address than postural. The postural ones, these are like the slam dunk ones where you know when you re-x-ray, if they're doing their exercises, they are going to look awesome. Structural is very, very, I don't want to say difficult. It's much more difficult to achieve correction, right? Think of it kind of like braces for teeth. You're truly remolding ligaments. Same thing with that head forward posture with those normal coupling patterns. Man, if someone's doing their exercises and wearing their head weights, it's like a slam dunk. You re-x-ray, you got a nice 35 or 40 degree cervical curve. Those are great, easy cases. And so those postural cases are very easy as well. And then this person, I would not have this person doing the Titanic. Here's why. The Titanic drives the rib cage forward. If he has no posterior translation, do I want to drive his rib cage forward? The answer is no. Secondly, the Titanic, especially because we have the person sort of push their hips back to the wall, will increase pelvic tilt, which will thereby also increase lumbar lordosis. This patient already has 61 degrees of lumbar curve. They have hyperlordosis of the lumbar spine. So it's important to understand this. This is not a Titanic patient. Here's someone I would lay on the ground, have them sort of contract their abs face down and do a prone thoracic extension. That would be a perfect exercise for this patient. You'd have basically everything neutral from pelvis down, trying to flatten the kyphosis and bring the head up and back. Okay, so very important to understand these nuances or differences. So structural hyperkyphosis versus postural. Okay, so I've tried to sum it up in bullet points. Structural, very little posterior translation of the posture. Thoracic kyphosis, usually 60 plus degrees. If for those of you who remember the pizza angles in the cervical spine, typically you're going to see a pizza angle over 75 degrees. And then they're going to have an evident kyphosis on their Adams forward bending test. So super easy test. If you have them in your office, you make them bend forward and you'll see that visible hump. I'll show you on the next slide. Postural kyphosis, usually going to have a very large posterior shift or posterior translation. The thoracic kyphosis will be, roughly 60 degrees, typically not more if it's only due to posture. Their pizza angle will be, 75 or under. They'll have a relatively normal pizza angle. And when they bend forward, they're going to have no bump on their Adams forward bending test. Super important to understand, though, and this is why I put 2 stars next to it. Not all patients who have kyphosis are going to fit into one category or the other. Guess what? Patients reserve the right to have a little bit of column A and a little bit of column B together. And those cases are obviously tricky. And this is where you become, a pro over time. And the more you do this, the more you choose, okay, maybe in this case, I use a thoracic dental roll. Maybe it's a retrainer. Maybe they need the Titanic, right? So not every case is going to be perfectly simple fitting in A or B, but I've showed you those cases that are. And hopefully that gives you those starting steps to say, okay, this is how we address thoracic hyperkyphosis, okay? Now, here is the Adams forward bending test. So if on their posture, I notice he's quite rounded, right, which this guy is rounded. So I would have them bend forward. And here's just like a minor one. So this patient, I would assume that they have a little bit of kyphotic deformity, but because he bends forward and it's pretty smooth arc, I would say a lot of his kyphosis is probably postural with very little structural. Him, on the other hand, if you look at that big arc, that's a whopping kyphosis. He is entirely a structural kyphosis with no postural deformity at all. Okay, because there's such a big arc as he bends forward. Also, it's structural because he has no flexibility. He can't bend forward, right? Those structural curves are extremely rigid. And so this is classic, like he can barely bend past his knees. That's him reaching as far down as he can, okay? Now, if you're not doing cervical films, I would highly recommend, again, using Posture Screen. It's a fairly cheap software. The cool thing is if you're not doing cervical films, the thoracic spine is the only part of the spine that can be measured relatively accurately through the skin. And I've done this over and over with my patients. I look at what's called the thoracic angle, which is more or less your thoracic kyphosis. So this patient measured 28 degrees, like the software just puts these dots or helps you put the dots on, and it measures the kyphosis, right? And so it measured 28 degrees, and on Posterior, he's got exactly 28 degrees. It's pretty darn accurate time after time. So if you're not doing thoracic x-rays, you can at least understand what's happening in the thoracic spine by doing this. The cool thing is it also measures your translation. So here, like they use more simple terms because a lot of like athletic therapists and trainers use this. So they just say shoulders are shifted forward by 0.83 inches. So you have, you know, just a little bit under an inch, and go figure. What's the normal coupling pattern for the thoracic spine to reduce? So boom, it matches. He has anterior translation with a reduced thoracic angle, a reduced thoracic curve. So if you're not taking x-rays, I would highly recommend getting this software and at least doing those lateral thoracics, okay? So quick recap, we have structural, we have postural. The reason we want to know the difference is because one is entirely a normal coupling pattern when it's postural. So very big translations, increase our thoracic kyphosis. That patient, you send them home on that big gray block called the posture regainer, and you have them do Titanic exercises. The patient that has the structural deformity, the exercise will be dependent if there's posterior translation, lumbar hyperlidorsis, but the main focus for them, even if you're not sure which exercise to give them, the main focus is using the thoracic general, okay? And if you are going to give an exercise, usually one of my favorites is prone thoracic extension for those patients, okay? As always, there's a coupon code for all the Warrior docs for being on these webinars and just continuing to be loyal construction spine specialists and continuing to apply these protocols in your office. So WQ223, it's for 10% off until June 13th. So basically you have 2 weeks from today to use that to purchase any general products and apply these in your office. And then you know the drill. There's my contact information in YouTube if anybody wants to watch the videos on how to actually implement these tools, okay?